good morning, everyone. So I'm Dorian. I'm here to talk a little bit about predicting the sick trauma patient. So I know in trauma, we like to think about turn the brain off, quick, dirty, easy, move on, OR, angio, and move on. But we don't like to think. But any of you all that know me or worked with me know that thinking is all I do. I just like to think. So let's think about our trauma patients and how we could predict how sick they actually may be. So when thinking about sick versus not sick, what we're actually trying to determine are two things. Number one is their mortality. Which patients are at risk for high mortality? And then two, what is their state of perfusion, hypoperfusion specifically? So we're going to be looking at some key things. Blood pressure, of course. Lab values that may or may not be useful. Something novel like end-tidal CO2. And something useful or not useful like IVC. So I don't think you need any help figuring out that this patient is sick. Or this one. Or this. Or this. Or this. Or even this. I love this picture. Sorry, I use it a lot. It's one of my favorites. So we don't need any help in determining that those patients are ones that we need to aggressively resuscitate. But the patients that we really need to be thinking about are the ones that we could miss. The ones that don't come in looking like those guys, but they still have something going on that we need to sniff out somehow. So what can we do to help us sniff that out? So welcome to paradise. So another day in Disneyland. So you know in Disneyland they pump all these scents of everything that's baking so that you are enticed to buy something, right? I think that's what like all our emergency rooms are. There's just some scent in there all the time that you just get and you're like, welcome home. So one day you're in paradise and the ambulance brings in a patient. A 32-year-old male. He was found down at the side of the road. He doesn't know what happened. He is more concerned about the fact that he can't find his shoe. His clothes are a little tattered, maybe an abrasion on his skin. He's ambulatory, he's awake, he's alert. He has no complaints. He says, Doc, I'm alright, I'm fine. I don't know what happened, I don't know where I was or how I ended up here, but I'd like to go home, please. EMS said that his initial vitals on scene was systolic of 90/30 with a heart rate of 110. But when he comes to you, he's 130/80. His heart rate's 84. He's walking around, he's chilling. And most importantly, he wants some apple juice. So this single snapshot that we see of our patients is usually the first trap that we could get ourselves set into. Because we see this single snapshot of blood pressure, patient presentation, time, and we say we instantly move that patient from the unstable to stable category. If the EMS brought the patient with that first blood pressure and that was ours, there would be no question. The lecture would be done. Everybody go home. But we have a patient that actually looks fine, but potentially could not be. So what factors can we use to predict what this patient's mortality may be and that we need to identify early on to actually save them and give them apple juice? So just one drop is a pretty common and pretty well-known paper about a single hypotensive episode. So a single hypotensive episode in a patient, those patients have been shown to have increased mortality in our trauma patients. If they have a recurrent hypotensive episode, it could double that mortality. We don't need to know specific numbers. It goes from 13% to 24%, but you're not going to tell your patient, excuse me, sir, you have a 24% mortality versus you have a 13% mortality. You'll just be like, if you leave the hospital, you're going to die. That's what you're trying to tell them. They understand that, more than 13% versus 24%. So we can't focus on that single snapshot and have to take everything into consideration. So you say, all right, Dorian, you know, if a patient is hypotensive, I'm not going to miss that. He's hypotensive, he's hypotensive. All right, we're going to take care of that. That is true. If a patient is hypotensive, you can't fake that. You can't fake a low blood pressure. So what else? Give me something more. Give me something better than that. All right. So we are looking for signs of hypoperfusion. So lactate is our biggest indicator of hypoperfusion that we use and we know and we love, from everything from sepsis to strep throat. So lactate, we can get it off our green tube, but ideally if we can get it off our blood gas, that's great for turnaround. Give us a 15-minute turnaround time on our lactate and give us actual bedside decision-making capabilities. If someone has a lactic acid that's sent off in a green tube and it comes back in 45 minutes to an hour, it may not be as clinically useful for a very sick trauma patient at the bedside, because in that hour, they may usually present themselves one way or the other, all right? So what else? So we're emergency medicine docs, and we don't like to think about big fancy things, but there's something nice else in our blood gas that we use called our base deficit or base excess. So let's add a little bit to that without going too deep into physiology. And there's some things that our surgeons have had a handle on before us, and this is one of those things. Base deficit. So base deficit or base excess simply relates to the change that's associated with bicarb that occurs in our bodies when our bicarb goes down as a result of buffering an acid, right? Big simple physiology. Base excess is what you may see on some blood gases, or base deficit. It's simply either positive or negative number. Normal is -2 to +2. Base excess is positive, means there's more base. Base negative is negative, so there's a deficit of base, right? So, patients who have a base deficit of less than 6, which I can get back on my blood gas quickly, even if I don't have a lactic acid on my blood gas, can be associated with worse outcomes and higher mortalities, especially if those patients have other factors put together with them. So this paper spoke nicely about some of those other factors. One of those factors we spoke about already, which was hypotension. So what is hypotension? The studies that actually looked at a number. We may think what? 90/60, 90/70, 90 systolic is usually what we think in our mind. But it's actually a little higher than that. 105, 110 systolic. A patient who's actually hypotensive below those numbers have worse outcomes. So a transient episode of hypotension plus a base deficit of -6, those patients have increased chance of having either or needing operative or angio intervention. Not to mention, if they have a repeat episode of hypotension, increases their mortality, it doubles it, you're just going to die if you leave. Or they have to go to the operating room for intervention. So okay, so far, we have some things in our mind. Our blood pressure we need to keep in check, some lab values. But I don't think there's any way I can convince a surgeon to take a patient to the OR because their base deficit is 6. We're going to need some more, right? So we like to get a little fancy sometimes. So let's add a little fancy tools. Our panel actually brought it up, asking about end-tidal CO2 and perfusion. So remember, our goal, we are in the business of maintaining perfusion. And end-tidal CO2 is a good correlation and marker for many different things. In our trauma patients, there's an inverse relationship to our end-tidal CO2 and to our lactate, or to our base deficit, and thus to our patient's actual need for operative intervention. So one of my favorite things I like to do is my stable, quote unquote, stable can be anything, right? Somebody with a heart rate of 0, blood pressure 0, that's a stable patient. So with awake, chest tube for whatever reason, pain control, I like to put them on end-tidal CO2s. It helps me measure their perfusion because I'm paying attention to what the end-tidal CO2 is doing. It also helps me monitor their oxygenation and ventilation and how they're breathing otherwise. So alright, so I have one fancy tool. Next fancy tool that may or may not be useful is looking at the IVC for these patients. So there's this study that came out, we'll talk about this one first, looks at the IVC on CT scan. So you may say, why is anyone looking at the IVC on CT scan? So this study was performed by surgeons, and at the point in time, maybe they are less proficient with ultrasound than they may have been before. So they looked at IVC being long and short, so not as tall. So a flat IVC having worse outcomes. So an IVC that was twice as wide as it is tall could predict worse outcomes in patients. So this was in 2013, but 1 year later in 2014, they did a repeat study with a larger number of patients looking at the exact same IVC parameters, and then they said, you know, it didn't make that much of a difference. So then we came by we I mean emergency medicine and ultrasound fans who are ultrasound gurus, and we look and we realize that the IVC can be useful for providing us a marker of volume status, and the correlation with ultrasound can give us a better idea of if these patients are under or over resuscitated or volume depleted as necessary. But the trick with the IVC is that you have to be pretty specialized, like many of you are, all you ultrasound gurus here, in identifying it. But there's no definitive marker as to where to measure, how to measure the angle, the size, the flow that has been standardized as of yet. But it has utility for our patients. So, okay, let's get back to our friend who had some apple juice. Initially was hypotensive, then he was normotensive, and he had some apple juice. So his basic workup of a chest x-ray and a pelvis x-ray was negative. His fast was negative. He had no complaints. But because we didn't know what went on, he didn't know what went on, a little more was done, including some labs. His blood gas, which came back before we done anything else or we even able to get him for any CT imaging, came back with a pH of 728, CO2 of around 32, bicarb of around 15, and a base deficit of around 8. I have lactate on a little green tube, so I'm still waiting for my lactate to come back. But I know that this patient is hypoperfusive. I just don't know where and I don't know how as yet. So while waiting to go for a scan, he vomits. After he vomits, he has a repeat episode of hypotension. So now I know if he leaves the hospital, he's going to die. So we do a repeat fast on him. And his repeat fast is positive, as we knew it was going to be. Ruptured bladder. Asymptomatic. Belly was non-tender. He had no complaints. Went to the OR. So, if we only think about those parameters alone, can we say that we can make a perfect decision on any patient? The answer would be no. Especially if we're trying to determine that subset of trauma patients that look well but may not be well. But there's certain things that, as I said, patients cannot fake. They can't fake physiology. You can't fake acidosis. You can't fake hypoperfusion. So we have to be able to identify those signs of what's called hypoperfusion. But one very key thing we didn't touch on yet, that actually is probably one of the best things we could use, and it is, and we do it all the time. They can't fake when they're normotensive and diaphoretic, when they have weakened peripheral pulses despite a normal heart rate, with a delayed cap refill in spite of the fact that it's summer or that they've been warmed otherwise. My cap refill is probably delayed right now. Yes, cool. So we have to keep these key features in our minds when thinking about predicting how sick our trauma patients are. Thank you.